My name is Kathryn Ruff. Very excited to be here talking to you today about a topic that's very near and dear to my heart. I'm an epidemiologist by training, so I do a lot of work thinking about study design and analysis to answer questions in what you'd call big medical data sources. So I've worked before in health insurance claims data and worked quite a bit with electronic medical records data, which is what the topic of my talk today is going to be about. And in terms of what applications I'm interested in for these data, I generally ask questions about medication safety or patient safety. So in the interest of full disclosure, it was mentioned before, I'm currently employed by Google, and all the work I'm going to present today was published as an editorial that was co-written with Dr. Thompson. So let's start with the very basics. What exactly is an electronic health record? So every time we have an interaction with the healthcare system, in the United States, it's pretty standard for this information to be collected and stored digitally. So an individual's electronic health record could contain medical history, diagnoses, medications, procedures, et cetera, kind of everything important that's happened during that visit. As I kind of alluded to earlier, these are becoming pretty much ubiquitous in the US healthcare system. So there were very strong financial incentives put in place around 2009, the HITECH Act. As a result, now more than 90% of US hospitals have an EHR in place. And these are collecting quite a bit of data. It's not uncommon for a single patient's hospitalization to create over 150,000 data points on what has happened while they were in the hospital. So this is a really dated statistic, but it still gives you a good idea of kind of the scale of data we're talking about here. US healthcare data alone reached 150 exabytes in 2011. This is kind of beyond the scale of comprehension. I think there's a lot of opportunities here to learn from this data that we're collecting and make the healthcare system better, make public health better. However, it's messy and it's complicated and it's not necessarily fun to work with. It was not designed with researchers in mind. So EHR data, it has a lot of potential, but it also has a lot of limitations. And adding just more and more data on top of it doesn't necessarily solve these fundamental problems. So how do we take the data we have available to us and draw useful conclusions that we can actually use to improve clinical care? So I'm going to start by going over just kind of some fundamentals that I'll refer back to throughout the presentation. Then we'll talk about the exciting opportunities that EHR data gives us from a medical researcher's perspective. Then we're going to talk through the pitfalls and what can be done to avoid them. And finally, we'll have some time at the end for Q&A. This might be kind of heretical to say in this audience, I don't love the words big data because I don't think they're specific enough unless we're purely talking about storage. From a research perspective, data can be big along a lot of different dimensions. So one way you could think about data being big is it's wide. So genetic data is a really good example of this. For a single individual, for a single observation, we have a lot of information. So a human genome contains over 3 billion base pairs. Not all genetic studies use full genome sequencing, but even in those kind of smaller scale studies, we're still talking about 200,000 to 2 million single nucleotide polymorphisms, which are just kind of like variations in one part of the DNA. Contrast this with census data, which is what I'd call long data. The US has this survey that's done every 10 years, and most lives in the US are covered by this. There's 117 million households, and it's estimated roughly 308 million individuals were covered by the last census. But we only have 10 questions. So the depth of information here is much, much less. The types of questions you can answer with census data look very different than the types of questions you can answer with genetics data. So what about EHR data? It's in some ways long. We can have, for a single large health center, anywhere from tens of thousands to millions of individual patients. It's also wide. We have a really big variety of types of data that are being collected on these patients. And then there's also a really important temporal component. For a single individual, they can visit a health center once and never come back again. Or we could have kind of a longitudinal 10-year history on what their utilization patterns look like within that health system. And we're going to circle back to this element later in the talk. So what kinds of questions can we actually answer with EHR data? And I'd say it's really kind of what we can, it's the same types of questions we can answer with any sort of observational health data. So there's descriptive questions, which kind of tell us about the burden of disease or how common a given treatment is. They can be very useful for resource planning. An example would be how many patients are diagnosed with hypertension each year. Then there's predictive questions. So this is where machine learning comes in. Can we identify the people at highest risk of a given condition or a given outcome? An example of a predictive question would be, which patients are at highest risk of developing hypertension? And we might care about this because we want to give some sort of preventative intervention or treatment. And finally, there's questions of causal inference. If we have to decide between multiple courses of treatment, what are the benefits and risks when we compare those? So an example of a causal inference question would be, when should I start a patient on antihypertensive drugs? Now, the degree to which we believe answers to any of these questions is going to depend on the data and the assumptions that are underlying kind of any statistical procedure that's being done. So I'm going to talk about some of the ways these assumptions might be violated and things to watch out for when we're working with medical records data specifically. So let's talk about the promises, what's exciting here. Because it's important to remember that there are really a lot of opportunities. So the first is scalable data collection. EHRs are extremely expensive to implement upfront. I don't think anyone would argue with that point. However, there's a relatively small marginal cost every time you add a single new patient or a single new observation for each of those patients to the data set. That's exactly what these systems were designed for in mind. It's a use case that has to be supported. Contrast this with traditional medical research. Each additional patient and each additional measurement on that patient, especially if it involves some sort of like laboratory processing, is going to increase study costs. So a lot of times investigators find themselves in the situation where they're trading off between having more individuals in the study and having more information about those individuals. So partially because of the scalable data collection aspect, we have just a larger number and a larger variety of patients in EHR data systems. It's going to include, by definition, any patient that's sought care at that clinical site since the EHR has been implemented. And that means we're also going to capture rare diseases, uncommon events, lots of different patient subgroups, and this is all kind of without anyone thinking about it beforehand. In traditional medical research, there's going to be a substantially smaller number of patients. Even the largest studies will rarely be above 10,000 patients. Depending on how we design the inclusion and exclusion criteria, a given study may not really be representative of any real-world population. And the recruitment is often condition-specific with a single disease or single treatment in mind. So by using EHR data, we have the opportunity to ask questions on a much larger number of patients, and also possibly on patients who have traditionally been excluded from traditional medical research. And then kind of along the wide axis of the database, we have a pretty large variety and depth of patient variables. We capture kind of anything that's necessary to take good clinical care of a patient. So all the procedures, all the lab tests, all the returned values, free text notes that doctors and nurses have written. That's all captured in the EHR. Now, whether or not it's used in an individual research study, like that depends, but it is in principle there. In traditional medical research, the scope of the variables is going to be constrained by the specific research question, and we're going to have to beforehand specify exactly what type of information we're going to need. So as a result, an EHR database can probably be used for a much wider variety of studies and a much wider variety of questions than a typical traditional medical research database. And the last kind of really big promise or opportunity here is the promptness and timeliness of research, because EHR data is being passively collected on an ongoing basis. It can be tapped into whenever there's an interesting research question that comes up. For traditional medical research, there could be a delay of years between coming up with a study question, collecting all the data, and being able to analyze it. Okay, so now time to move into the pitfalls, which in some ways are a little bit more interesting. The first pitfall, and one that's talked about very, very often, is poor data quality in EHRs. And this comes from a variety of different sources. So I've just put a couple of them here, but this is by no means an exhaustive list. The first would be errors in data entry. There are EHRs filled with all sorts of implausible lab values. I doubt any patient has ever had a 98-degree-centigrade fever, but if you look at almost any hospital system, you'll see at least one of these measurements. There's also a lot of important information on the patient that's not necessarily covered in structured data. It might be hidden in text, or maybe it's in an image that's not part of the EHR. Doctors can also physically see and examine patients and may or may not write down their findings. So there could be some really important missing bits of information. If we are relying on structured portions of the EHR, things like diagnosis codes and procedure codes, there is a phenomena of what's called upcoding, where we're not sure if a patient has a condition or not, but it still gets coded anyway, or a condition is made to seem more serious than it actually is, and this is kind of perverse reimbursement strategy. So that's definitely something to be aware of. Depends what perspective you're coming from. And then there's also errors in data processing. So I work a lot with medications. It's not uncommon to have like 5, 6 different timestamps that all refer to a single medication order. It could be, when the order was initially placed, different timestamps where there have been updates to it, when the medication is first supposed to be administered, when it's no longer valid. If you accidentally kind of mix up your timestamps, it's very easy to get a sequence of events that makes absolutely no sense. And there's a lot of these decisions that have to be made along the way as we're doing an analysis. So what happens when we have poor data quality? What happens when we see these types of mistakes in studies? it means we're going to have inexact measurements of things like our case definitions, the inclusion and exclusion criteria, the features we're feeding into a model, and the actual outcomes we care about. So what can be done? So I highly, highly encourage anyone working with this type of data to actually look at the data, check your assumptions, do a sanity check. And on top of that, if you have like a candidate definition, like say using diagnosis codes or procedure codes to identify patients with a certain condition, do a validation study or find one that's already been published. And when I say validation study, kind of have a group of specialists, usually clinicians, take a look at people who meet your case criteria and then determine whether they actually have the condition or not by doing a full chart review. Okay, pitfall number 2 is patient loss to follow-up, which is the temporal aspect I alluded to earlier. So most EHR systems are only going to have information on a patient's interaction with that system. So if it's a single hospital, if you go to another hospital, those records might not be linked. So this is an example of what patient data could look like. So let's pretend we care about post-surgical complications after a knee replacement. So here the purple dots can be when the knee replacement actually happened. Gray dots would be kind of just any interaction with the healthcare system, and a red dot would be a diagnosis of the infection we care about. So it looks here like we have one patient who has a post-surgical infection. But what we see is not necessarily what happened. So here, the outlines of circles are intended to be something that happened at another site or another facility. We miss some of the encounters. For the second patient, it looks like they were receiving care elsewhere and only came to the site for the procedure itself, which is not at all uncommon. And then the fourth patient actually died several months after the procedure. It usually is not captured in a medical record when these types of deaths happen outside the healthcare facility, but that might matter a whole lot to you if you want to understand post-surgical complications. So in terms of what can be impacted here, descriptive studies, you can undercount events, which is just kind of what we walked through there. In predictive studies, you'll have incorrect outcome labels, and this can bias performance metrics because even your test set is incorrect. In causal inference studies, there's a phenomena called selection or collider bias. Essentially, the point estimate you get won't necessarily reflect what you were trying to actually estimate. We're going to come back to causal inference in a couple slides. In terms of what can be done, in some cases, we can link to additional outside data sources. So the Social Security Death Index is a really good example, especially if you care about something related to patient mortality. In some cases, it might be a time to step back and rethink whether EHR data is actually the right thing to answer this question at all. If you need longitudinal data and you need it to be uninterrupted, using insurance claims data might be a better choice because that will follow patients across different facilities, even if those facilities have no relationship with one another. And finally, in the setting of causal inference, we can do something called quantitative bias analysis, which lets us know how much loss to follow-up, like how bad would it have to be to completely change our conclusions. Okay, the third pitfall is an overemphasis on statistical significance, really chasing the p-value less than 0.05. There has been a lot of very heated, active debate among the statistical community recently. The top article was published in Nature just a couple weeks ago and is causing quite the stir. I don't know if we need to retire statistical significance completely, but there are some really important considerations when we think through using these large data sets. So the first is that Statistical significance does not necessarily mean something is clinically significant. So statistical significance is going to depend on kind of how big the magnitude of the effect estimate, but it's also going to depend on how precisely we are able to measure that in each one of the populations. So as you increase sample size, the p-value shrinks, even if the size of the effect stays exactly the same. So you can have trivial differences that have a p-value of less than 0.001. There's also a similar related problem around model misspecification. So anytime we're doing statistical modeling, that's going to come with some underlying assumptions about the data generating process and what the true distribution looks like. If we pick the wrong model, if we violate those assumptions, we're going to produce estimates that are in some way biased. Kind of paradoxically, as we get more precise in our estimate, the confidence interval shrinks. And in a way, we are more likely to exclude the true value when we have this model misspecification. The last issue is p-hacking and data dredging. Essentially, it has to do with researchers toying with the data until it gives them the answer they would like to see. Lots and lots of subgroup tests. And it comes from this dogma that it's easier to publish a positive result than a negative one. So I think I've already talked about what can be impacted, but let's talk about what can be done. So if you want to present p-values, please also report clinically meaningful effect estimates. It helps put into context how big of a change we're actually talking about. To cut down on the type 1 errors and p-hacking, doing things like pre-specifying analyses and reporting all subgroup tests regardless of statistical significance is also good practice. So Pitfall 4 revolves around using these types of data for causal inference. It's in no way specific to EHR data. It really applies to any observational health data you could be working with. It's a phenomena called confounding. Essentially, the treatment or exposure we care about has a common cause with the outcome we care about. And this is pretty common because we decide whether or not to treat people based on how sick they are or how healthy they are. So a really, really well-documented example, and there have been like a number of statistical papers on this phenomena, is influenza vaccination. So older adults are more likely to have pretty severe influenza complications if they get infected with the virus. As a result, doctors really try and get these patients vaccinated, so we see much higher rates of vaccination in older adults. However, if you naively compare the groups who have been vaccinated and who have not been vaccinated, and you don't control for age, it looks like influenza vaccination is causing influenza complications. This is not the case. Once we take into account age, this disappears. So naive analyses can lead to very, very misleading results. And again, if we harp on statistical significance, you also will find p-values less than 0.05 here. Causal inference studies, there's a whole field dedicated to doing this correctly and articulating the assumptions that need to go into these analyses. There is no way I can do it justice in the next 5 minutes. The theme of most of these methods is that causal inference studies should be designed with kind of an ideal target trial in mind. If you'd like to learn more, there's a resource I really like to recommend. It's a textbook by Hernan and Robbins. It's written with beginners in mind. It's really, really wonderful, and it's freely available. And the hyperlink is there. So the last kind of pitfall I want to talk about, and I'm not sure if it's a pitfall, but it just didn't feel right to not talk about it, is reporting. These studies with EHR data they can be really important and really influential. And we have to make sure that we're reporting things in a way that can let decision makers, policymakers, clinicians make an informed decision about whether or not they believe the results that are being presented. There are some really helpful guidelines. The STROBE statement, or strengthening the reporting of observational studies in epidemiology, or the RECORD statement, reporting studies conducted using observational routinely collected data. It's a mouthful. These provide pretty helpful checklists and kind of a bare minimum of what we should be doing when we're reporting these types of studies. As researchers, we really have a responsibility to transparently report all the methodology, to thoughtfully think through what the assumptions we're making are, what the limitations are, and to be circumspect and responsible in our conclusions. So EHR data, I hope I've convinced you, are really exciting. They can enable new, otherwise infeasible research directions, and some of this will be directly applicable to clinical care. However, we really need to think carefully about the assumptions we're making and the underlying data generating processes, because it's also really easy to make mistakes and make kind of misleading conclusions if we don't think through each action we're taking. So I'm going to finish there, and I'm happy to take any questions.
Let's start in the back here.
Yeah, it seems like one issue as a whiny-old person with too many doctors is that, like, another problem with an EHR is my EHR is distributed, right? So I'm part of the UC system, and I have like multiple. I'm in UC Health. The dermatologist who monitors me for spots is in another system. My primary doctor is in another system. 2 out of the 3 have Epic-based portals, which are like fairly awesome, within themselves, but don't talk to each other. And I'm just wondering, like, is there some solution that would allow me to, someday give you my record, the whole thing? Because you're missing pieces also because part of it's here and part of it's there, right?
That's a really great question. And there's some excellent work being done on interoperability. There's an organization, an interoperability standard called FHIR, F-H-I-R. I think like the Apple Health Kit is using FHIR. A lot of the work we're doing at Google to harmonize between all these different EHR systems is using FHIR. I hope it catches on. I think it could be a really promising way forward. But what you are saying is in no way unique. And you're absolutely right that it doesn't even have to be across systems. Even within systems, sometimes clinics will be on different systems that don't like to talk to one another.
So it was a great talk. The paper, the Nature paper on statistical significance, I just want to point out that they were at least equally, if not more, concerned about the other direction, not so much the p-hacking, but the idea that, something with a sample size of 5, you can't really get statistical significance, and yet if you kill 2 out of 5 patients with your drug, that's an important result to report, even though the statistical significance isn't there. So I just want to point out that that they're sort of worried about underreporting as opposed to finding spurious results only.
Yeah, no, I completely agree with that too. In the setting of big EHR data, we're usually more worried about this, but point well taken that small clinical trials, a p-value of 0.06, but it's doubling mortality risk. I wouldn't want to write that off either. Yeah, definitely.
There's one here, one there, and then over here. Bunch of questions.
The data is kind of not very clean, as I understand, and whatever the inferences you make may not be really conclusive. So, but seems like there can be a way to basically analyze, are you making the right conclusions? Means maybe there may be multiple ways of trying to conclude and see it really makes sense. So means even the data is bad, we can basically some entity or somebody can basically validate, are they coming in with the right conclusions or are they not? So is any work done on that space so that to validate, are you using the data and making the right conclusions.
I think that was the validation studies I was referring to earlier. Like, are what we're coming up with, the definitions we're coming up with, actually reflective of the patient experience? I'll also say that having someone on the team that's actually a clinical expert, like a medical doctor, is extremely valuable. To get these things right, there has to be input not only from like statisticians and data scientists like me, but also from the clinical side of things, because it's really easy to make mistakes and you have to constantly be checking yourself. So I don't know if there's a panacea, but we need to be validating these measures and doing lots of common sense checks that we're not making kind of silly mistakes.
No, I got that point from your presentation, but what I'm saying is, even on top of that, there would be a way to validate just from statistical point of view. Like if you take different sets of data or try to do the modeling differently, can we reach the same conclusions? And that way we can basically reduce the confidence on the conclusions just looking at the data. So it can be done automated way too, and it can be done by third party as well. So
how would
is
it
there
be done
any?
in an automated way?
Well, that you could
Oh,
perhaps
you're-
automatically
you're-
detect upcoding and
Means-
throw those outliers out or something?
Yeah, so
Let's
some
try
of
to use
this, like
different
the outlier
samples.
elimination, could absolutely be automated. Some of it, like choosing which timestamp, can't.
So there is a lot of manual selection of data involved. Is that what you're
Yeah,
saying?
yeah. There has to be subject matter expertise. Absolutely, it can't be automated.
Okay. And back?
If I may come back to this question about small sample underreporting, because I'm not quite sure I get what you're suggesting. The underreporting, for example, of out of 5 people, 2 died, in my mind is justified because the small sample is small. I cannot make any valid conclusions out of it, and maybe on the whole, if somebody's combining a big data set of these small samples, I could see the value in it. But if somebody is going to publish something, I'd like to know whether the conclusions are valid or not.
Well, I think we like to dichotomize things as like right or wrong, yes or no. The way I think about it is perhaps a little bit more Bayesian. Like I want to see the effect estimate, I want to see the confidence intervals, and look at like the full range of values that are compatible with that confidence interval. And if most of the confidence interval is indicative of harm, but there's a small bit that like crosses the null threshold, I don't want that drug. Technically, you're correct, but I think the argument that was being made in that paper, and which I also agree with, is sometimes it's a little bit more complicated than just like yes or no. Like I'd come to very different conclusions based on what effect estimates are compatible with that 95% confidence interval.
So, Stephen?
In the early part of the discussion, you observed that the cost of putting in these systems was very high initially, but the marginal cost of collecting additional data and so on was relatively low. Physicians don't seem to agree with you, and and they're very important for getting high quality data.
You are
and
100%
so
correct. Yes.
What I observe is if you don't pay for the data to be there, it won't be there. So if we pay for outcomes, you'll get outcomes data, but you won't get the procedure data. If you pay for service, you get the procedure data, then you don't get the outcomes data. If you pay for everything, then you're probably paying too much. So there's a lot of issues in getting the right data and the cost of getting it.
Yeah. So one huge caveat about EHRs that I did not go into is they're not particularly user-friendly. Clinicians hate them. It's one of the most cited causes of clinician burnout right now. There's a lot of work to be done there on making these systems actually be useful for doctors. I'm cautiously optimistic that we're going to start to move in that direction, but I think you're absolutely right. And when I mentioned earlier the upcoding, like that's all tied to the fee-for-service model. If we reimburse for something, it's going to be much, much better documented than if we don't. So yes, I agree with pretty much everything you just said. We need to make these systems better for doctors to use. It's going to increase the quality of the data. It's also going to increase the quality of care the patients get.
But it means you get bias in the data because what they
Absolutely.
do is they put the easy thing to put in that they know is going to pass the edit check.
Yes.
And it gets through, and now you've got bad data. And it's not missing data, it's bad data.
Yes, but I still think it's useful data. So if you take it as ground truth, you're absolutely right. It's not 100% correct. It's misleading. But if you take it in the context of knowing upcoding is a phenomenon, you can still glean useful information from this data most of the time.
I'm not just talking about the upcoding, oftentimes to make it easier to use the system, there'll be menu systems where they can just select, just top of the list,
Yes.
bang. Doesn't
I've
has any
seen-
effect on
Yeah.
compensation.
No, I've seen amputees that someone's copy and pasted notes that say like left foot good, right foot good. And they don't have either of their feet. So like it's very clear that's being copy pasted. I think there's certain data elements you trust more than others, and ones that are easy to automate, you should be more distrustful of than others.
Oh, over here.
Hello. Just now I didn't get your point. Can you explain a little bit more about why will you say statistical significance is different from the clinical significance?
Yeah. So I think the discussion we've kind of been having here is that statistical significance is usually just defined as a p-value less than 0.05. An example of something that could be statistically significant that is not in any way clinically significant, like a 0.5 point reduction in blood pressure on average between two groups. If you have enough patients, that can be statistically significant. But if you talk to a clinician, if you talk to a patient with hypertension, a 0.5 point reduction in their blood pressure, it's essentially meaningless. Does that help clarify things?
Yes. In my point of view, I think statistical significance should be the same with clinical significance. The difference may come from the data you used to represent the clinical significance. I think you maybe I'm not sure whether I'm correct or not. I think both statistical significant and clinical significant are not totally correct in both sides. That's my opinion.
In a way, it depends on how you're defining your outcome variable, right? If your outcome variable is
Absolutely.
just the measurement of the blood pressure, then you can get these kinds of results. But if it's that you got a clinically significant reduction in blood pressure, then the statistical significance and clinical significance line up.
Yes, I mean, you could design your statistical significance test in a way that it will only be positive if there's a clinically meaningful effect, but that's in practice. I don't see very many papers doing that. But I think in principle, it is possible to change the paradigm of statistical significance testing in a way that makes it more clinically meaningful. But I think at bare minimum, we need to be reporting the effect estimates. That a p-value in isolation really doesn't tell us much about kind of the direction of the change or the magnitude of the change.
Okay. We have a few more minutes.
As more and more health systems start to collect genomics data, and typically that's not being reflected in the HRs, but each of those two could be really enlightening to the other. I'm just curious if your research has gone in any direction on that yet.
So I have done no genomics research yet, but you're right that it's increasingly useful in some clinical applications, especially around, say, tumor sequencing. I think there's some really exciting opportunities there, and I think there's a lot of really bright people thinking about precision medicine and how genomics and genetics might inform treatment decision-making. So it's not an area I've looked into a whole lot myself, but I definitely see the field moving in that direction.
It's somewhat off topic here, but this data is very sensitive. How do you plan to protect it for long term and in this internet world?
Oh, yeah. That's another thing. So if you'll notice, there were no calls here for more sharing of data or more openly available things, because this is highly, highly sensitive and highly private information. All the work I do is on de-identified medical records, so a lot of elements have been stripped. There's also, say, logging of every interaction I have with the data that's audited. There's a whole field that's dedicated to thinking about exactly these concerns. I can probably not give you an adequate answer, but I think it's incredibly, incredibly important for us to be thinking through these things, because these are patients coming to us at the most sensitive time in their life, and these data need to be protected and need to be kept safe, and that should be priority number one.
Yeah, but I understand. Also, like there are other data sets which may be totally unrelated, such as like Facebook feed, that can kind of show some correlation between the medical history and the like moods detected on the Facebook post. That can be something which can be utilized together. But now one is being so private data set. How would you basically access these two different kind of data sets together? Just as an example, it can be anything though.
I think anytime you're talking about something like that, it's going to need to involve patient consent. I don't see any other way around that. Informed consent by someone who wants to be involved in that type of research. It's not something I've worked on specifically. I think it's something you can do, but there's a lot of risks and a lot of benefits. And I think it should be up to the patient to make the decision about whether those risks and benefits are acceptable to them.
So kind of a question that I have that's in a way related to this. I mean, privacy is, of course, one area where medical records have been forced to implement many systems that are ahead of what other domains have. Another one is, I think, you're fortunate enough to have a complete ontology of all the diagnoses and all the procedures that it's hard to get in other domains. Are there other kinds of areas where health records are kind of ahead of the curve and they have lessons to teach other domains, perhaps in some of the causal inference areas or in other areas?
So I think there's a lot of great work being done in the medical field around causal inference. I also think in the machine learning world, there's a lot of interesting work being done in reinforcement learning. I think those two fields have a lot to learn from one another. But in terms of like medical technology, medical systems are still the biggest users of fax systems. So they don't tend to be ahead of the curve on most technology adoption. They're by nature conservative. They need to make sure that patients are safe. They can't really experiment all too much. So in general, I think they tend to lag behind, but in terms of like statistical methods, there's a lot of great work that's going on.
Okay, thank you very much. And we're going to have, I guess, a break until you want to cut it a little short. Yes, yeah, cut it 5 minutes off, so we'll come back at 3:10 p.m. Thank you very much.
Thank you.